I'm grateful to BNMS for asking me to talk on the overall management of neuroendocrine tumors. My name is Tahir Shah. I work at Queen Elizabeth Hospital, Birmingham, running a neuroendocrine tumor center of excellence. These are my declarations. This is our discussion plan, so we will restrict ourselves to well-differentiated low-grade neuroendocrine tumors only, their incidence, presentation of the common types, such as gastrointestinal, pancreatic, and bronchial carcinoids, workup for surgery and other treatments, treatment options, and prognosis. Neuroendocrine tumors can begin anywhere in the body, which means you need a large team of experts to manage them effectively. The situation is further complicated by the fact that you have low-grade, well-differentiated and reasonably well-behaved cancers which don't respond to the usual chemotherapy options. And then there is another group of cancers with some neuroendocrine tumor differentiation, which may respond to chemotherapy, but for which the evidence for efficacy of any treatment is very limited. Putting things into perspective, there were 352,000 new diagnoses of cancer, I think relating to the year 2019. The commonest was breast cancer with 54,000 new diagnoses, and neuroendocrine tumor was quite rare with 2,000 new diagnoses in the year 2013. What we see here is that the incidence of neuroendocrine tumor has been steadily rising. This is very likely related to the growing use of endoscopy and cross-sectional imaging in the general population. This is data from Public Health England. They discovered 8,726 neuroendocrine tumor neoplasms diagnosed in England in 2013 and 2014. A breakdown of one of the years shows that there were 3,500 patients with grade 1 neuroendocrine tumor and 445 with grade 2 neuroendocrine tumor, and these map to the commonest site being, for the primary being the lower gastrointestinal tract, followed by the upper GI tract, which includes the pancreas, and then the lung. When we look at the 1 year survival, then we see that for stage 1, 2, and 3 disease, it's almost 100% for patients with grade 1, grade 2 well-differentiated neuroendocrine tumor, and it drops to about 80% or just over 80% in stage 4 disease. But when we look at the survival in patients with other cancers and some neuroendocrine differentiation, then their survival is significantly lower. So how do these cancers present? The gastroenteric cancers, well-differentiated grade 1 and 2 neuroendocrine tumors, are often found incidentally on endoscopy. So gastric carcinoid and duodenal polyps are found on upper GI endoscopy, and rectal neuroendocrine tumor polyps are picked up increasingly on colorectal cancer screening and colonoscopies. Then there are discoveries on incidental imaging for other reasons, such as prostate cancer staging or breast cancer staging. Then you have patients developing irritable bowel type symptoms that could go on for years until somebody might decide to arrange a CT colonography or an ultrasound scan of the abdomen, for instance. Patients can also present acutely with abdominal pain or obstruction and go on to have emergency surgery. Then patients may develop Carcinoid Syndrome, though this is hardly ever picked up by clinicians. and it's almost always missed until someone arranges an ultrasound scan or a CT colonography for the diarrhea symptoms. Occasionally, patients present with carcinoid heart disease related heart failure. Patients can also rarely present with Zollinger-Ellison syndrome, consisting of indigestion and diarrhea, and when you scope them, you find esophagitis, gastritis, and duodenitis. Patients can also present with bleeding and anemia, either from the gastritis and esophagitis in Zollinger-Ellison syndrome, or sometimes the primary lesions may ulcerate and bleed. For pancreatic neuroendocrine tumors, they're often being picked up incidentally on imaging. The abdominal discomfort and weight loss as a presenting feature is that of late disease. Insulin hypersecretion in insulinoma leads to early diagnosis, however, when the tumors are less than 1 centimeter and are easily cured with surgery. And pancreatic neuroendocrine tumors can also be gastrinomas. As you may remember, gastrinomas occur in the gastrin or gastrinoma triangle, which is bordered by the pancreas, the duodenal part 1 and 2, and the common bile duct. Bronchial carcinoids usually present early due to bronchial obstruction and infection. They are then surgically removed and are often node negative, meaning about 80% will have a curative operation. They can be found incidentally when being staged for other cancers or other conditions. They very rarely present with Carcinoid syndrome now, and they can also present with Cushing syndrome because some of the bronchial carcinoids can secrete ectopic ACT. Here is a representation of the natural history of carcinoid tumors. So this is the subgroup of cancers that begin in the small bowel and metastasize to the liver, leading to hormone secretion into the systemic circulation, resulting in facial flushing, diarrhea symptoms, the carcinoid syndrome. What we see is that they grow slowly over a very prolonged period of time. They metastasize locally and then to the liver, and eventually the volume in the liver is sufficient to release enough hormones into the systemic circulation to start causing the carcinoid symptoms. And we used to get these patients diagnosed in quite advanced stages when they were suffering with facial flushing, diarrhea, possibly losing weight, and were then being referred to the neuroendocrine tumor teams. And what we're seeing with the advent of increased cross-sectional imaging and endoscopy is patients being diagnosed much earlier in the disease course. So perhaps 5 or 10 years earlier than they would have been diagnosed otherwise. This does improve our ability to intervene earlier. Whether that has any benefit long term is yet to be discovered. Neuroendocrine tumor centers have to be able to offer a whole range of therapies for these patients. Our first consideration is always surgery and whether a curative operation can be performed even when there is distal disease. If this is not feasible, then patients may require surgery for symptom relief, such as bowel obstruction, heart failure due to leakage from heart valves, or sometimes debulking surgery is required for intractable symptoms from hormone release. There are a number of effective treatments for controlling cancer progression, such as somatostatin analogs, everolimus, sunitinib, sometimes chemotherapy, and occasionally interferon can be helpful. The big breakthrough in the last 5 years or so has been peptide receptor targeted radionuclide therapy, when a clinical trial demonstrated its effectiveness and is now become standard practice as second-line treatment. And then there are interventional radiology options that could be tried, such as ablation or transarterial embolization. CERT is no longer available, neither is SABRE in the UK, and brachytherapy is only performed in very highly specialized centers, of which only 1 or 2 exist in the world. When we are planning surgery for patients, we need to have as much information as possible to make sure we make the right choice. Sometimes there is much more disease than initially visible on a CT scan, meaning surgery is not a good option and systemic therapy should be applied. At other times, it's a question of making accurate diagnosis before embarking on surgery. The tools we have available are a CT scan, and a CT of thorax, abdomen and pelvis provides a good overview. MRI of the liver is the best way of imaging that organ, and then DOTA-PET imaging is by far the most sensitive way for looking at neuroendocrine tumors overall. Endoscopic ultrasound scan is probably the best modality for imaging the pancreas, and occasionally a laparoscopy may be necessary to ensure there is no miliary disease before embarking on major surgery. Tumor markers are helpful for tracking tumor recurrence, and very soon we are starting a liver transplant program which will have its own pathway for extrahepatic cancer clearance followed by liver transplantation. Here is a case of a young man who was found to have a 9mm rectal neuroendocrine tumor polyp on cancer screening, and the team at Stoke went on to do an MRI of the pelvis, finding indeterminate 8.1mm lymph node in the perirectal fat. They asked for our advice, and we arranged a DOTA-PET scan, which showed in fact 2 lymph nodes, and the patient went on to have surgery to remove these in Stoke, and remains under follow-up with them without recurrence so far. The evidence for the use of somatostatin analogues, sandostatin, which is long-acting octreotide, and lanreotide autogel, which is another long-acting somatostatin analog, comes from 2 randomized controlled studies, PROMID and Clarinet, both of which showed significant increase in time to tumor progression with these agents, and they remain, in fact, standard of care and first-line treatment for most neuroendocrine tumors. The evidence for the use of everolimus comes from the RADIANT studies, the last of which, RADIANT 4, showed clear evidence of progression-free survival, whether measured centrally or by the local teams, as well as evidence for overall survival benefit. This is the data from the NETA study, which used lutetium dotatate in one arm and double dose octreotide in the other arm in patients with progressive neuroendocrine tumors that were already being treated with somatostatin analogues. There is a very clear and large difference in progression-free survival, and also a substantial improvement in overall survival with the lutetium dotatate. Chemotherapy still has a small part to play in the management of well-differentiated neuroendocrine tumors, particularly pancreatic, bronchial, or those with slightly higher Ki-67 of 5% or more. The evidence essentially comes from case series, and the treatment of choice presently is capecitabine temozolomide combination. Interferon was one of the first therapies shown to be effective in neuroendocrine tumors, providing good control of symptoms as well as likely providing control of the cancer and likely leading to some benefit in progression-free survival. However, the evidence is old and comes from case series rather than controlled trials, and it is a difficult drug to use with significant side effects and requiring close monitoring, particularly for bone marrow suppression. It has therefore gone out of favor as the availability of octreotide and lanreotide um, led to a better treatment option for the patients. So here is a summary of the likely choices in systemic therapy. Somatostatin analogs have become the go-to drugs for managing all neuroendocrine tumor types. They are used first line for stage 4 disease, and their use is based on good clinical trial data. Everolimus is also very good and can be used first line or second line for stage 4 disease and is evidence-based medicine once again. PRRT, or peptide receptor targeted radionuclide therapy, is excellent treatment and is presently licensed for second line use after disease progression on somatostatin analogs. Chemotherapy, the present favorite regimen is temozolomide capecitabine combination. It can be used first line for rapidly progressing disease, but is often used third, fourth, fifth line for controlling cancer growth. Interferon has been shown to be effective in gastroenteropancreatic neuroendocrine tumors. It can control symptoms and likely controls disease progression, but it is difficult to tolerate and requires specialist monitoring. It has fallen out of favor, but is still used occasionally. So, what are the determinants of prognosis in our patients? Obviously, the stage and grade, as was demonstrated by the Public Health England data. Then there is the volume of disease. So in some patients, you may have stage 4 disease, but very small volume, and they will have an excellent prognosis. Symptoms and complications are usually signs of advanced disease, although occasionally patients can present with early complications such as GI obstruction from a primary before there has been distal metastases. Then there is the general fitness and nutrition status of the patient. The fitter and healthier patients are, the longer they are likely to survive, the more treatments they're able to cope with. And finally, there is very importantly the psychological state of patients. So often someone may need extensive interventions in order to bring them back to health, and they need to be in a good state of mind to be able to cope with this, which can be difficult. Patients can be overwhelmed by the number of issues that they have and how many treatments they will need to get things under control. Another very important determinant of prognosis is the place you are managed. This is data from Uppsala, the first special center for neuroendocrine tumors, and they compared the outcomes at their center with the Sears data, and you could see a clear doubling of prognosis of outcomes of longevity when being managed at a center of excellence. Finally, this is the size of the team that helps us look after neuroendocrine tumor patients at Birmingham. It has steadily grown and will continue to grow. Here they are at our Thursday afternoon neuroendocrine tumor MDT meeting. Thank you very much for listening.